Hi guys, welcome to another lecture in the series Medicinal Chemistry 1, and today we're going to be talking about anticonvulsants. So you may be familiar with the terms anticonvulsant or anti-epileptic drug or AED. Well, they're used interchangeably in the literature to describe a diverse group of medications used clinically to provide seizure control in patients with epilepsy. So, epilepsy is actually the most prevalent neurological disorder affecting more than 0.5% of the world's population, and it is characterized by recurrent seizures unprovoked by any identifiable causes. So, the etiology of epilepsy is largely unknown, even though recent evidence suggests that it may have a genetic component associated with its disease development. So these seizures are symptoms of disturbed electrical activity in the brain, and you generally have episodes of abnormal, excessive, and synchronous discharge of a group of neurons within the brain that cause this involuntary movement, sensation, or thought. So seizures actually may result from primary or acquired neurological disturbances of brain function as a result of an imbalance between excitatory and inhibitory processes in the brain. So there are many possible causes of seizures, and they include brain tumor or infection, whether or not you have a head trauma, neurological diseases, systemic or metabolic disorders, alcohol abuse, drug overdose, or toxicities. So this is a problem with AEDs. So most of these newly diagnosed seizure disorders can be effectively controlled in the beginning or initially, right, with the use of these AEDs to prevent reoccurrence of seizure activity. So some examples of these AEDs include Valproic Acid, and we'll be talking about that one, as well as the phenytoin in particular, but there are others. So the problem is that the success of the pharmacotherapy of epilepsy with these conventional AEDs is often hampered by the loss of effectiveness after prolonged drug exposure. So that's not good. A third of newly diagnosed patients become resistant to current pharmacotherapy. So seizures, they are classified based on their initial signs and symptoms and the pattern seen in the EEG, right? And the two broad categories are generalized seizures and partial seizures. And as the name suggests, partial seizure, that's seizure activity that starts in one area of the brain. So notice what we said here, that it's categorized based on their initial signs. So initially, for the partial seizure, the seizure activity starts in one area of the brain. For the generalized seizure, it involves the whole brain. Consciousness is lost at the onset. So this is the entire brain consciousness lost at the onset. And that is divided into 4 types. So we see here myoclonic, which is sudden muscle jerks. We see here tonic or atonic, and that is drop attack or abrupt fall, either with stiffening or loss of muscle tone. And there is absence, which is the staring trance-like state. And there is tonic clonic, that's convulsion with loss of consciousness, stiffening of the body, then jerking of the limbs. So those are the generalized or symptoms of the generalized seizures. For the partial seizure, they are divided into complex and simple. So for simple, the patient remains alert. So for example, jerking off the limb, etc. And it may spread to the whole brain and become tonic clonic, right? As well as the partial is also divided into complex, where it is the altered awareness and behavior, for example, confusion, repetitive movements. And just to note that it may also evolve into generalized or whole brain seizure. So that brings us back to our initial point, which we said was that it's based on the initial sign. So even though it might be partial or generalized on the onset, the partial may evolve into the generalized. So for the EEG, right, each of the epilepsy types is characterized by an abnormal pattern in the EEG. So while I'm no specialist at reading the EEG, I have two pictures here which shows the differences between the normal awake EEG versus the myoclonic seizure. So obvious this difference is here between both, right? So the EEG indicates sudden excessive electrical activity in the brain. Most of the currently available AEDs work by preventing or stopping or lessening this electrical activity. So let me repeat that. Most of the currently available AEDs, they either prevent or stop or lessen this electrical activity. And so the precise causes of these abnormal changes is still unknown. All right, so there are a few mechanisms of action by which anticonvulsants they do their work, right? So at the cellular level, there are three basic mechanisms that are believed to contribute to this anti-epileptic action of the currently marketed anticonvulsants. And currently within the scope of this lecture is based on the text, right? So the first mechanism is the modulation of voltage gated ion channels. So your sodium, your calcium, and your potassium. So the second is the enhancement of the GABA mediated inhibitory neurotransmission. And the third is the attenuation of the excitatory neurotransmission in the brain, which is glutamate mediated, right? So that is the lessening of the excitatory neurotransmission in the brain. So many of these AEDs, especially the newer ones, work by more than one of the above mechanism of action. And so they have generally a broad spectrum of anti-epileptic action. So this is just an overall diagram showing various AEDs and what the mode of action that they are connected to, whether it be voltage gated modulation of that channel, as we mentioned before, modulation of glutamate or reducing the glutamate activity. So as we see, various drugs and, whether it be GABA enhancement. So the type of drug, as I said earlier, that they have more than one mechanism of action. All right, so that leads us now to question 1, which says, what is myoclonic seizure? And part B says, describe any one mechanism of action of anticonvulsants. So for the myoclonic seizure, it is a generalized seizure in which the individual experiences sudden muscle jerks. And the one I selected, the MOA that I selected for part B, is the enhancement of the GABA mediated inhibitory neurotransmission. And your question is, what is absence seizure? And describe another mechanism of action of anticonvulsants. So we mentioned 3, I called 1, and you should select another one. All right, so for these voltage gated ion channels as targets for anticonvulsants. So voltage gated sodium channels, and we call them VGSCs, in the presynaptic nerve terminal of the excitatory glutamate receptors are the molecular target for phenytoin that I mentioned that we're going to talk about, and some others. So these aromatic aeds, they inhibit excessive neuronal firing by binding to a site near the inactivation gate, thereby prolonging inactivation of these sodium channels. For the voltage-gated calcium channels, they are essential in regulating the calcium signaling, which is associated with many important cellular events such as the release of the excitatory glutamate neurotransmitters, the plasticity changes of long-term potentiation in learning and memory, and the maintenance of homeostasis of the nerve cells. So these are clearly very important. So it has been suggested that excessive influx of calcium plays a critical role in the induction and the progression of epileptic seizures. So we can understand, therefore, why this channel would be a target of anti-epileptic drugs. For the GABA A receptor targets, well, it is now well recognized that cellular excitability leading to convulsive seizures can be attenuated by GABAergic stimulation in the brain. So we looked at the GABA receptors previously. So we should have a clear understanding of what is happening here. So the GABA A receptor is one of 2 ligand-gated ion channels responsible for mediating the effects of GABA, which we know already. And we also know that it is the major inhibitory neurotransmitter in the brain. And activation of the GABA A benzodiazepine receptor chloride channel complex allows increased chloride conductance, thereby preventing the spread of neuronal excitations. So we are already familiar with this particular target because we did look very closely at the benzodiazepines. So the potential targets for the AED's action for the GABAergic receptor inhibitor synapses include, well, drugs that enhance the biosynthesis of GABA, drugs that inhibit GABA degradation, and drugs that inhibit the reuptake of GABA, as well as drugs that bind to an allosteric site at the postsynaptic GABA A receptor complex that increase chloride conductance. So we are familiar with our benzodiazepines, right? And from this category of drugs, we are going to be focusing mainly on our VPA, which is Valproic Acid. So it's a drug that enhances the biosynthesis of GABA. All right, so VPA, as I mentioned, is an established AED with a simple chemical structure, but an unusually broad spectrum of action. So it is generally well tolerated, but its use is limited by 2 rare but significant toxic side effects. So there is hepatotoxicity and teratogenicity. So as you would have probably picked up, the first has to do with the liver, and the second, that is teratogenicity, has to do with the study of abnormalities in physiological development. And the toxicities, they can be dose dependent or idiosyncratic in nature. All right, so these toxicities are apparently shared by its equipotent active metabolite, which is E, and I hope we remember our chemistry here, E2-propyl 2-pentanoic acid, right? And so here we have the structure of valproic acid. So as we said, it's a very simple structure, right? And this is showing the different routes of metabolism. So you will have beta oxidation, so the hydroxyl was added here, and then we have dehydration to form an active metabolite here, and you have various things happening. You have oxidation to an inactive metabolite. So clearly a lot of possibilities for the metabolism to form either a toxic metabolite or an inactive metabolite, right? So let's look at the synthesis of valproic acid. All right, so we start off with an ester, right? And we have an alkyl halide here. Well, 2-to-1 ratio in terms of the stoichiometry. And we have a base in the form of sodium ethoxide. So this base do what bases do, right? What do bases do? Well, they pull protons, right? So these protons, even though we're not seeing them here, are very acidic because they are connected to electron withdrawing groups. So that makes the carbon hydrogen bonds weaker than normal. And so once they're weaker, they're more acidic, right? And so the base can pull those protons to form an enolate, which is a carbon ion, a negatively charged carbon here, which will now be nucleophilic and attack our electrophilic center or carbon here, causing displacement of our bromine. So while we don't necessarily need to know the mechanism, it's good to understand reactions on a mechanistic level so that we don't have to swap them. And I do expect that you will know the synthesis of valproic acid. Now, so the base will actually abstract both protons, and be substituted. Essentially, they're substituted with 2-propyl units, right? Substituents. And once that is formed, then you basically have hydrolysis of the ester and decarboxylation to form this intermediate, which is then hydrolyzed by base again to the carboxylic acid. So very simple and clear synthesis here. All right, so the other drug that we look at is phenytoin, right? And it is 5,5-diphenylhydantoin, is a prime example of an effective anticonvulsant acting through its action at the VGSC. So for phenytoin, this is the structure. So we have the diphenyl 5,5-diphenylhydantoin. So this is that, the structure here, and the phenytoin is very effective against all seizure types except for absence. However, the drug may be incompletely or erratically absorbed from sites of administration because of its very low water solubility. So even though it's very good, the water solubility is an issue. So for this reason, Fosphenytoin, a prodrug of phenytoin, and we know what these are, was developed and marketed to avoid complications such as vein irritation, tissue damage, etc. So fosphenytoin is rapidly absorbed either by intravenous or intramuscular administration. So basically, fosphenytoin is the phosphate of phenytoin, right? So that's the prodrug, that's the structure here. So it is converted into phenytoin through phosphatase catalyzed hydrolysis of the phosphate ester. So we have the phosphate ester here. In the presence of the phosphatase enzyme, it is converted to phenytoin eventually. All right, so this is the metabolism of phenytoin, right? So by now, guys, you need to be able to look at a structure and postulate how do you think it is metabolized in vivo, right? And so here we see hydroxylation. So the principal metabolic pathway of phenytoin in humans is aromatic hydroxylation, catalyzed by these CYP enzymes, which we've seen several times, right? So clearly we have hydroxylation at several areas here, and that is the main thing. Yes, there's epoxidation, etc. But the main or principal pathway of metabolism is aromatic hydroxylation. All right, so this leads us to our final question in this portion, which is draw the structure of, should have been of, E2-propyl-2-pentanoic acid. And the question part B says, is it an active, inactive, or toxic metabolite of valproic acid? Take a second. All right. So this is the structure of that, right? So we have pentanoic acid, and we have the propyl at position 2 as well as the double bond at position 2. And we need to also remember our EZ. So on what basis is this E versus Z, right? And so this is the correct structure, and it is an active metabolite. So the final question is, propose a synthesis for valproic acid. So this is the end of this section, and thanks so much for watching, and see you next time.